So we are starting with our next session, Whiplashing the tardive colon. Does it help? And the moderators for the session are Dr. Ankush Bansal, Dr. Anurag Govil, Dr. Monty Bhagat, Dr. Vishal Khurana, and Dr. Roopjyoti Datta. And the chairpersons are Dr. Neeraj Govinda, Dr. Rajendra Charangu, Dr. Roshan Kafle, and Dr. Ram Babu. Now I would like to invite our first speaker, Dr. Sukrit Sood.
Okay. So, good morning everyone. So, I've been given the task of discussing our current endoscopic weight loss management strategies, especially in liver disease. So, we know we are dealing with a pandemic of obesity, and what comes with obesity is a multi-pronged attack on multiple organs. So, we have diabetes, we have MAFLD or MASL now that it's called, and these are all turning into chronic pandemics as well, and our country is going to be in the midst of it, and it's going to be the MASL capital very soon, if it's not already. Problem is, still the causes are poorly managed. We try to attack the symptomatology and the after effects without working on the basic causes. And the prevalence is ever rising. So this is the basic pathophysiology, how we deal with MASH as it's now called, how it ends up with cirrhosis and sometimes rarely liver cancer and end-stage liver failure. So basic disorders of insulin resistance. We have the X gene, which is rampant in our country. We have PNPLA mutations as well. When we are doing genetic testing, we are getting more and more patients who will have a more rampant course of their MASH. And we now, for obesity, we may depend only on restrictive therapies, but when there's a primary metabolic disorder, we need better therapies, which are called metabolic therapies. Both, to some extent, can be managed endoscopically as well, besides the known surgeries. So for restrictive therapies, we have the gastric, endoscopic, bariatric, and metabolic therapies. First is the balloon, which has been there for a while, but the balloons are ever changing. We have now balloons which can be resized and volume can be increased or decreased as per tolerance. And we have the Spire Assist, which never took off really because of its issues of nutritional deficiencies. And then we have the endoscopic sleeve gastroplasty, which has been there for a while, but due to cost constraints never took off, but now the numbers are going up. Then we have small bowel EBMTs, which is the endo barrier, which helps in creating a barrier at the D1, D2 till the D3, so we can have a better incretin response. And then we have duodenal resurfacing, which I will be coming to later. The physiological basis, the effect of weight loss on obesity and its complications. See, 5% total body weight loss can cause improvement in your cardiometabolic risk profile. But at least 10% total body weight loss is needed if you want to improve diabetes, cardiovascular outcomes, and liver fibrosis. So this is the basic tenet when you see a patient in the OPD, what are your targets, how you're going to achieve them. So intragastric balloons are easy to deploy, does not require much endoscopic skill. Now we even have the swallowable balloon, which I have personal issues with because you do want to rule out contraindications for balloon therapy, and the cost of the balloon is very important as well. The cost sometimes is inhibitory, and the swallowable balloon is for a shorter period, around 4 months. And the adjustable balloon goes by SPATS, has been there in India for a long time, now has FDA approval as well for the last 2 years. And then the conventional balloons like Orbera, which cannot be resized, and reshaped duo, which is a couple of balloons tied together. So this was Baram Abudai's meta-analysis back in 2015, published in Endoscopy, 17 Orbera studies, these are all on Orbera. And excess body weight loss at 1 year was 25% and total body weight loss at 1 year was 11.3%. So quite impressive considering they have not used any drugs alongside, just balloons. And they have a limited stay in the human body from 6 to 12 months depending on the type of balloon. So obviously lifestyle modifications are a must even in the standard arm of these studies. So then there's another study by Bazarbachi 4 years ago, 21 odd patients. They want to study biopsy based improvement with their NASH. So 21 patients, mean BMI 44, early liver fibrosis, balloons were placed, and they underwent pre and post liver biopsies studying their histopathology. So the NAFLD activity score did improve significantly in post balloon patients, and the MR elastography scores improved as well. So this was quite quite a revelation at the time that we were making changes at the histopathological level, not necessarily in fibrosis, but in inflammation and steatosis for sure. Then there was another study around 4 or 5 years ago, multi-center European study and American center as well by Reem Shira and Ivo Boskowski. And they included all these studies and they found that over a long-term follow-up between 6 to even 20 months in a single study, your LFTs do improve, and your NAFLD activity score was also shown to be improving in studies which took up liver biopsies post-procedure as well. And MR elastography showed improvement in fibrosis. So this was a large review and meta-analysis by Christopher Thompson's group, one of the pioneers of endobariatrics, now one of the pioneers of gastroplasties. So 10 RCTs and 30 observational studies, 5,500 odd patients. Overall fall in HbA1c was only 0.6%. We don't expect a very large fall because it's just a restrictive therapy. Waist circumference improved significantly, 4 centimeters, and the fasting blood glucose, the blood pressures, LFTs, and lipid profile did improve significantly. Adverse event rates were very few, 1.3. Mortality was extremely rare. So this was the newest study from AIG group. So they also studied the SPATS balloon, which is an adjustable balloon for metabolic dysfunction associated steatotic liver disease, similar to Baram's study and Bazarbachi's study, where they studied the total body weight loss was around 12%, and NAS activity score on biopsies, 91% of the patient showed improvement. And balloon adjustment and 25 patients, upward adjustment was associated with further NAS improvement. So the benefit I see in my practice with the adjustable balloon is tolerance. Indians do not tolerate very large balloons usually, especially Indian females. So we start at a 300-350 ml volume with 50 ml of air. So we give buoyancy to the balloon and we can increase the volume till the 750 ml at the end of 3 to 6 months as per tolerance. Then the relatively new kid on the block is sleeve gastroplasty. We are doing these actively now because there was a lot of great data from the MERIT trial, again led by Baram's group, and a lot of American centers, Reem Shirai, Christopher Thompson all participated. So multi-center RCT, 9 centers, both surgeons and GI physicians took part in these 200 odd patients, BMI roughly around 35, class 1, class 2 obese patients were taken up. Durability was studied at 2 years and the impact on the comorbidities, be it BP, sugars, metabolic syndrome or reflux. So the results were that patients had excess body weight loss in the sleeve gastroplasty group of 49%, very good, and total body weight loss around 14%, still moderate, and comorbidity improvement in majority, 80% showed comorbidity improvement. At around 2 years follow-up, 68% of these 60 participants in the sleeve gastroplasty group maintained to at least 25% of the excess body weight loss. So this was impressive as well. So when the patients were surveyed after the study, 80% were highly satisfied at the end of 1 year and would recommend the same procedure to their friends or families. And safety was great as well, only 2% severe adverse event rates, and the perigastric abscess were reported rarely, upper GI bleeds which were easily managed endoscopically, and malnutrition were the common issues. Then sleeve gastroplasty was also studied by Reem's group and was published, 91 odd patient, 20% total body weight loss at 2 years, HbA1c significantly improved, blood pressure, waist circumference, and ALT improved as well. So this was one of the beginning studies showing benefit in liver enzymes as well. Similarly, AIG group led by Dr. Rakesh Kalpala showed that their parameters all showed improvement at 1 year post ESG. Their ALT levels went down. The histological indices, FIB4, APRI all showed significant improvement. Then similarly, Christopher Thompson's group also showed improvement in the liver biopsy. Changes on biopsy also showed improvement significantly along with the liver enzymes and steatosis. So coming to now the duodenum-based metabolic therapies, basic physiology is incretin response. So I can skip this. When we take in food, we have insulin spike because the releasing factor increase. When incretins rise and the balance maintain euglycemia, but we eat sugary food, our actual insulin resistance goes up, blood sugars, triglycerides, all will lead to MASH eventually. So the basis is endoluminal approach may actually decrease insulin resistance. Then came the study on endobarrier, which did not take off, had issues with the hepatic liver abscesses were there, even though they had significant improvement in liver indices and biopsy. So the newest kid on the block is duodenal mucosal resurfacing. Earlier RFA was used, now we have other methods as electroporation has taken up now. Not available in India yet, but we are looking forward to it. Though similarly thermal ablation is done, we can achieve similar results with APC. Some authors have said So that we are excited about as well. So improvement in glycemic and liver indices in type 2 diabetics was studied in this study by Jacques Devier's group. So they showed improvement in everything, HbA1c, their liver enzymes, their insulin resistance, lipid profile, antioxidant capacity, and anti-inflammatories as well. The Vivanta study was a revelation. It improved HbA1c, insulin resistance parameters, and ALT and AST as well. I think I can skip this. So now the newer therapies are based on laser, RF, and electroporation. This is again Bharam's work. Endogenix is based on non-thermal pulsed electrical field ablation of duodenum from D2 till D3, which allows it to regenerate, simple, less than 30-minute procedure, and does not have any issues which are related to heat. So no complications like perforations or bleeding. Similarly, this has been studied. So both Endobarrier and Revita has been studied. Both showed improvement in liver enzymes, and additional FIB4 improvement was shown by the Revita group. That is the mucosal resurfacing. So what are the advantages of endotherapy over surgery? Relatively safe, good efficacy, adjustability with balloons, reversibility is there even with sleeve gastroplasty if you need it to be, acceptable and taken up easily, and satisfaction levels are high. So to conclude, we can achieve sustained weight loss, more than 10% total body weight loss, which leads to reversal of MASH and early cirrhosis. Diet and exercise alone may not be adequate for sustained weight loss with the level that we need. Endoscopic bariatrics are now best suited to provide patients weight loss needed for reversal of liver disease, and is more acceptable than surgery for most of our patients with class 1 and class 2 obesity. And identifying predictors for patients who may or may not respond is the next important studies which are required. So we have to separate our patients who are obese. They may need restriction with balloon or gastroplasty with or without the metabolic therapy with the resurfacing, and lean MASH or lean MASLed need only metabolic therapy with duodenal mucosal resurfacing. So thank you everyone. I'll take this opportunity to invite everyone for the next edition of the Endoscopic Premier League by our group at Vivanta on April 17th and 18th next year. Thank you everyone.
Thank you, Dr. Sukrit. Now I would invite our next speaker, Dr. Nirmal Malhi, for his talk on Sigmoid volvulus, the new twist in untwisting.
Hello, good morning, everyone. So at the outset, my sincere thanks to Professor Anil Arora and the entire team of Sir Gangaram Hospital for an excellent academic atmosphere, and it's a true academic delight, which many of us have witnessed for the past 2 days, and it's my proud privilege to be part of it. So the topic which is I'm going to speak over the next 10 minutes is something which is very sparingly discussed in the gastroenterology forums, but far more commonly seen in the GI surgery forums, and that is on sigmoid volvulus, a new twist in untwisting. If we go by the very etymology of volvulus, the whole origin comes from the Latin word which is volvere, which itself means to twist. So twisting of a loop of bowel around its mesenteric attachment is what volvulus is. And we all know, because of certain predispositions, sigmoid colon is the most commonly part of the bowel which undergoes twisting, or the volvulus. And why it becomes an emergency is if there's a delay in diagnosis or institution of any therapy, there's a very rapid compromise of the blood supply leading on to bowel ischemia, necrosis, and perforation. One very important aspect, which again very few of us might be knowing, is like we have the seismic belt or the earthquake-prone zone on Earth. Now in the latest studies, the guidelines have reported a volvulus belt. That means there are certain parts of the globe where you see this condition far more commonly compared to other where you see it very sporadically. So Africa is actually right the central part, then Brazil, Middle East, and India. So they actually constitute 80 to 90% of all cases of volvulus worldwide, and remaining world is only 10 to 20%. So this is endemic volvulus versus sporadic. The reason is multifactorial, which I think we can discuss during our question answer sessions. And the two very important risk factors for sigmoid volvulus is, one is anything which causes redundancy of the sigmoid colon, advancing age, neuropsychiatric ailments, and the bottom line is they have a long-standing chronic constipation. And there's a certain morphology of the sigmoid colon which predisposes to it, which is called dolichosigmoid, which could be congenital or acquired. The dolicho again literally means elongated. So it is like you see here, there's an ascending and a descending limb. So it's an elongated and a widened sigmoid, but with a very narrow route of attachment of its mesentery. So we have an elongated sigmoid against a very, very narrow route of its attachment, so causing it to twist and giving rise to volvulus. The classical presentations is abdominal pain, constipation, and abdominal distension. And the important thing about distension is you have a progressive distension, but relatively empty left iliac fossa. That's how clinically it used to be distinguished from its differential diagnosis in cases of acute abdomen. Two important modalities for making the diagnosis of sigmoid colon. One still is plain X-ray of the abdomen, and other is, of course, is CT abdomen. So very few conditions where still plain X-ray plays a very important role. One, of course, is intestinal obstruction, other is perforation, and third is sigmoid volvulus. So this is, here you see, hugely dilated sigmoid, twisted, going on the right of the midline, and you have a central cleft, which you see here. If you see an X-ray of this thing, there's no other differential diagnosis but a case of a sigmoid volvulus. Another reported sign is called the northern exposure sign, where actually sigmoid goes all the way almost till the right dome of the diaphragm. And here, this is over and above the splenic flexure or even the transverse colon. So again, these are very classical signs, and the diagnostic accuracy of these signs is very, very high. So even if you take the sensitivity part, almost in 6 out of 10, you're going to get 1 out of these 2 signs on plain X-ray of the abdomen. And other important, which is the gold standard, which is almost an accuracy touching 95 to 100%, is of course the CT, where you see the sigmoid all lying on the right side, and here you what is called as the whirl sign. There's a twisting of the mesentery, and this is CT in one of our patients. So what you see here is a sigmoid colon, and this is where actually the whole sigmoid mesocolon is twisted. It is called a bird beak appearance. It's also called the whirl sign, and this is the non-dilated rectosigmoid. And this finding is very, very classical of sigmoid. And then you can also assess about the ischemia or any gangrene which is setting up. Now coming on the part of what they've told, the twist to the whole process of untwisting. If you go by the guidelines, there are a number of guidelines available. The latest two being, one is the ASGE guideline and other is from the Surgical Society of Emergency Surgeons. So you have to assess, resuscitate, and confirm your diagnosis. And most important is, if there are no peritoneal signs, that means there's no mucosal ischemia or gangrene, endoscopic decompression followed by perrectal tube placement is the standard of care, followed by sigmoid colectomy, preferably during the same admission, because the recurrence rate following decompression and detorsion are very, very high. And almost vast majority of patients without peritonitis can very safely be handled with this approach. The exact terminology which has been used worldwide now, it is called EDDR. That means an endoscopic, decompression, detorsion, and reduction. So basically, three things we are doing in the whole procedure, which I'll be showing a short video immediately after this. So the preparation, we actually don't need any bowel prep. It has to be done in an unprepared colon in left lateral position. A standard colonoscope or a pediatric colonoscope is the preferred scope. We have to go in, rectum is invariably empty in these patients. You have to first identify the distal torsional point, which is generally at rectosigmoid. Gentle insufflation, we have to go in, and then there's a closed loop obstruction of the sigmoid colon. It's a hugely dilated gas and liquid stool filled colon which is there. We decompress. That will show in those steps, I think, we better understood in this video. Yeah, notes. So this was actually a patient who came with a sigmoid volvulus. There were no peritonitis or mucosal ischemia. So rectum is always empty. And this is the endoscopic whirl sign you see. So there is spirally twisted folds, and this is normally at the level of rectosigmoid junction. So gently we're to go in, and once we go in, this is a hugely dilated and distended sigmoid colon. Some early signs of mucosal ischemia, but that's quite okay. And then we go on sucking, doing a suction of all the gas and the liquid stool which is there, and at the same time going further towards the proximal torsional point where you see another whirl sign, again the twisted loops, and there again you go gently into the dilated proximal colon over and above the twisted. Here you have to do a detorsion and reduction. That means a clockwise torque, and you have to shorten your scope. And by this, normally this thing is able to come back to its shape, and then you have to do it under fluoroscopy, and you can see that the whole sigmoid colon, which is lying on the right of the midline, tends to get back to its original position. Very high success rates, but the major problem is a recurrence rate, so people tend to keep colon decompression tube in situ for next 1 to 3 days, followed by elective surgery before discharging these patients. So what is a new twist? The new twist is this beautiful study which has come last month in GI Endoscopy, and this has come from Israel, 118 patients, where they actually looked at the exact timing of this procedure. Should we do it very urgently? That means less than 6 hours, or it can be delayed also. So what they could infer from this study was that if you look at signs of ischemia, success of your endoscopic detorsion, your in-hospital and delayed mortality of 30 days, nothing was much different if you do it very urgently versus even you do it around 12 hours from your diagnosis. So meaning thereby, someone comes in the late evenings, you need not rush to take that patient to an endoscopic suite and do a detorsion. The best would be you resuscitate, build up the patient, and maybe over the next 6 to 12 hours, which could be a good timing of proceeding with the colonoscopic procedure of decompression, detorsion, and reduction. And then there was an editorial which came by the same name, the new twist. New twist is not too urgent or emergent. If it is possible, do it. But if it is not, then possibly resuscitate, doing it anywhere between 6 to 12 hours. There's no going to be much harm in that, and we're going to have the good results. Definitive, of course, is the surgery. There are two different surgeries, whether you do a definitive resection and primary anastomosis versus a Hartmann's procedure in people who come with perforation peritonitis. Again, one of our own patients, this is how the whole necrotic sigmoid colon, and this patient actually had a iliosigmoid. So there's a sigmoid colon and part of ileum was also taken out. So ladies and gentlemen, I'll just summarize with my last concluding slides, and that is, in all cases of sigmoid volvulus, if there's no peritonitis, decompression and detorsion is the first thing. It succeeds in majority, but generally because of a high recurrence rate, you have to go for a sigmoid colectomy, preferably in the same admission. If peritonitis or there's an ischemic bowel on colonoscopy or detorsion is unsuccessful, you have to take patient for surgery. For emergency surgery, it's Hartmann's procedure, but if it's a viable bowel, then you go for a primary resection and anastomosis. So final thing, any elderly patient with distension and constipation, sigmoid volvulus need to be suspected as a clinical possibility. X-ray and CT are wonderful modalities for diagnosis. Decompression should be the first line if no peritonitis. But more importantly, the latest study, which is a new twist, is the timing. Maybe anywhere between 3 hours to 12 hours is a good time if patient reports you early. And if, of course, bowel is gangrenous, you go for an emergency surgery. Otherwise, electively, once you stabilize the patient, to convert a 2-stage into 1-stage, surgery still would be the definitive answer to the treatment. Thank you, and thank you so very much.
Just would like to ask you, this EDDR is very nice, but if the bowel is ischemic,
Right.
and the duration is prolonged, you need to go for the surgery. And you need to have a colostomy, in the sense the bowel is an unprepared bowel.
Yes.
So anyway, very nice of you.
Thank you. EDDR only will do once we are very sure there's no peritonitis. We do an imaging, and imaging doesn't show any swelling of the peritoneum. Then we proceed with that. We try to get the sigmoid back to its normal shape, keep a rectal tube in situ. We give 1 to 3 days time, and then the surgery, actually the morbidity of the surgery, which becomes much lesser, and we have a single stage surgery for these patients.
Thank you.
Hello.
Can I just ask?
May I have a question, please?
Can I just ask a question, please?
Yes, yeah,
Professor Sadiq from Aligarh.
right.
What surgery have you done? I mean, after decompressing and waiting for a few days, maybe I don't know how much days you have waited. What surgery was actually done after decompression?
The standard surgeries, if bowel is not ischemic, we have already derotated our sigmoid colon. It has to be a sigmoid colectomy and resection of the sigmoid mesentery.
I mean, was it a single stage
It's
procedure?
a single stage procedure, yes.
Resection of
And
the
then we're doing a primary anastomosis, end-to-end anastomosis.
end-to-end anastomosis.
Yes.
Because usually the things are so hugely dilated,
Right.
we become very, I mean, the chances of leak even after decompression, I don't know, we never kind of anastomose if we are doing it without decompression.
Right.
You are doing it with decompression and doing it after 3-4 days and anastomosing, but still, I mean, we are not very comfortable with that idea, because sometimes we find that the bowel is 15, even 20 centimeters dilated. I don't know how much normal it becomes after 3-4 days of decompression. Still, it will take some courage to join in that in after 3-4 days.
But that is the average time. So if still bowel is quite dilated and there's no ischemia, one can wait even a little bit extra as well. One can go for maybe another 1 or 2 days more, and once surgeons are very comfortable that they can proceed with a primary anastomosis, so it can be done at that point of time.
Thank you. And all, I mean, laparoscopy are open.
If bowel is, the procedure is endoscopic, but surgery is, yes, laparoscopic if bowel is decently decompressed at that point of time.
Thank you.
So what are the
Can I
options
just
to
ask a
prevent
question?
recurrence in non-surgical candidates?
Yes, there are certain people, because this is a disease primarily of the elderly population, so many people, because of many comorbidities, might not be fit for at any stage of for surgery. Then majority of these, they will come back with the recurrence of the sigmoid volvulus. We have one of our patients who come from Himachal for past 2 years, and he had 6 distinct episodes, but never was found fit to undergo surgery, but each time undergoes an endoscopic derotation and almost gets an average 3 to 6 months without the colon undergoing a torsion again.
There is a method by which we can do percutaneous endoscopic sigmoidopexy.
That can still be done, yes. Percutaneous methods of sigmoidopexy, or even for cecum, there's a cecopexy. So that also is possible.
Okay, thank you, sir. So with
So
that, we
thank you so very
conclude the
much.
session.
Right.
Thanks all the moderators and chairpersons. So the final session, Unravelling the Enigmas of Mysterious Pancreas. And the moderators are Dr. Pranil Rai, Dr. Alok Mishra, Dr. Subodh Adhikari, Dr. Madhura Prasad Suman, and Dr. Abhinav Jain. And the chairpersons for the session are Dr. Dinesh Shrestha, Dr. Gaurav Garg, Dr. Sadiq Akhtar, Dr. Sukrit Sethi, and Dr. Nihar Ranjan Das. And the first talk is current recommendations for prevention of post-ERCP pancreatitis by Dr. Ajay Kumar.
Thank you. As usual, wonderful meeting and great efforts of Anil. Well, friends, I've been asked to speak on current recommendations for preventing post-ERCP pancreatitis. I'll try to make it a step-by-step approach, and also to take up wherever the 2 major societies, that is ASG and ESG recommendations, and give you a clear answer about that. We all know that post-ERCP pancreatitis is an endoscopist's nightmare, and this is something, the incidence has not changed over time, and almost 5% of the total, I mean, if the total is around 10%, the 5% of them used to be the severe pancreatitis. And of course, we should differentiate it from simple asymptomatic hyperamalasemia, which occurs in almost 75%. But this paper by Venkata was there day before yesterday at CMC Vellore in the pancreas meeting, is doing wonderful work from Johns Hopkins. This updated review and meta-analysis of 145 randomized controlled trials published 2 years back has shown that the overall incidence over years has not changed. The severity has come down, but then 10.2% is the overall incidence. And in spite of the fact that we understand who are the patients who develop pancreatitis, in spite of the fact we know the prophylactic measures that we can take, still the incidence is significant, so all of us have to be cautious about it. Coming on to the recommendations, the first recommendation is select the right case. If indication is inappropriate, only then you do it, otherwise don't do the diagnostic ERCP. In today's era, there is no role of diagnostic ERCP. Caveat is, because I deal with a lot of post-transplant biliary complications, there you may not see dilatation of the bile duct biliary system, and you may not see the small strictures. Radiology may not be all that helpful. Sometimes in those patients, when you are stuck up, we have to do a diagnostic ERCP to document whether there's a biliary complication or not. Other than that, in today's time, I don't find there is any role of a diagnostic ERCP. And Professor Peter Cotton's 2001, he wrote, ERCP is the most dangerous for those who need it the least. And that comes out from the second recommendation. Identify high-risk patients on basis of patient-related risk factors, because this is something which you have beforehand, before you do the procedure. And why I said that patient-related risk factors, if you note from the bottom third line or the fourth line, fifth line, normal bilirubin, non-dilated bile duct, suspicion of SOD. These are the high-risk factors. So that's the reason why Peter Cotton says, if the yield is going to, the least, these are the people you can do without ERCP, diagnostic ERCP. And most important are patient-related risk factors, and that I will, when you identify them, patient-related risk factors, please reserve it for experts. It is cleared in a teaching center, it becomes challenging, but if you have a high-risk factors, Shyam's study has shown that there is a major difference when the expertise is good, and success is more than the complications. And this is another study from China which has shown the similar sort of a thing, that the ideal volume load of 150 ERCPs per year is one of the important criteria of being called the expert. And the next recommendation, now when you have a patient going for ERCP, there used to be a debate on whether you give a prophylactic endo-diclofenac suppository for every patient or for a selected patients, high-risk patients. Here you have to be secular, that is prophylactic suppository for everybody. Earlier data was mainly on indomethacin, but now you have almost equally good data on diclofenac. The reason I'm saying is in North India at least, now the problem is over, but we did not get the indomethacin suppository. We used to get only diclofenac, so we used to use that. Enough data to show that pre-ERCP, and usually it is given within half an hour of starting the procedure or during the procedure. And mind it, please remember, you are officially, legally supposed to take the consent of the patient. It's not that you induce the patient and then put the suppository. Some patients can create problems for you. So you need to take a consent for the suppository. And so what does the society say? American Society says among unselected patients undergoing ERCP, peri-procedural rectal NSAIDs given to prevent post-ERCP pancreatitis with a strong recommendation and with a moderate quality of evidence. And European Society says universal usage of rectal indomethacin in view of low cost and safety profile. You see, in US, the indomethacin suppositories are expensive. They were very late in prescribing it to everybody. They used to earlier give to high-risk patients, but now they have also changed. And in India, that's not an issue with this. The next recommendation, that rather than contrast or pacifying, use the guide wire. It has been shown, and ASG's recommendation is, in unselected patients undergoing ERCP, wire-guided cannulation over contrast-guided cannulation to minimize the risk of post-ERCP pancreatitis, which is a conditional recommendation with a modern quality of evidence. Now the next, identify. See, we talked about the patient-related risk factors. Now we say identify technique-related high-risk factors, which you will do only after you've done the procedure. And these are the different things. And here I have highlighted the difficult cannulation of biliary orifice. Because this we have to understand what is difficult cannulation. Now, the European Society has defined 5-5-1 rule, and that is more than 5 minutes, more than 5 contacts with papilla, and more than 1 inadvertent PD cannulation. So, one doesn't come into that. If 2 times you have gone into the PD, you take it as a high risk. And if you're shown that if you take 3 to 5 minutes, post-ERCP pancreatitis is less than 4%. And if you take 5 minutes, it goes up to 8%. And then if you have more than 5 attempts and PD cannulation, it goes up to 14%. So this principle, formula 5-5-1, is important for all of us to see. And of course, for the trainees, they have given a longer time. And there are advancements to understand that the type 2, which is a flat small papilla, has the highest risk of post-ERCP pancreatitis. It's not a part of any recommendation, but we need to be aware of that. And there are, of course, new machine learning models coming up, combining all different factors and giving you what is the high risk. I'm not going to that. Time does not permit us that. Now, next comes recommendation number 7. That is prophylactic PD stenting. We all know that this was the first modality which came to prevent post-ERCP pancreatitis, and this is a meta-analysis without going to the data of that. So I will show that what has come is PD stenting was prescribed in high-risk patient. Now, this particular study by Almunzer et al., if you remember, Almunzer was the one who published an NEJM study on the rectal indomethacin. Now, he has come up, there is a big debate going on between competition, as if it is a competition. He has shown in Lancet study 2024 that combination of the two is better than the single. So, right? But then, do you put PD stenting in everything? Case for PD stent placement in high-risk patients, even in those where you have to make special effort, cannulate PD. This is a tricky issue, because if you are going into the PD repeatedly, then there is no debate, put in a stent and come out. But if you are, and of course there are specifications for that, there is a 5 French, 2 to 5 centimeter and so on. But should we make extra effort? There is a debate whether we should do that or not. I personally will not make an extra effort to get into the PD, because if I fail to get into PD, I am fearful that my risk of post-ERCP pancreatitis even maybe more than the normal. But here, with this study, the combination of the two, people have started talking about that you should make an effort. ASG recommends PD stenting in patients undergoing ampulectomy, and PD is repeatedly or deeply accessed. But if you look at the last abstract in the last DDW, and there they have shown that even in patients with an ampulectomy, do not make extra effort to get into the PD, because it does not make difference. But that's debatable. As the things stand today, we will make stenting here, prophylactic stenting is essential there. But in patients with difficult cannulation, history of post-ERCP pancreatitis or pre-cut sphincterotomy, it is as long as PD access can be easily achievable, then do it, and don't make an extra effort, because sometimes the effort to prevent may boomerang. There is a big debate on aggressive fluid peri-procedure. I'm not going to what are the various ringer lactate, aggressive or the like it in the acute pancreatitis, same ways here. But the biggest problem here is that you need to keep the patient in the hospital for 1 day, because you have to give it for 8 hours till we find a shorter duration fluid, which is some data that it helps. It will be difficult for us to follow that. But yes, if it is a very admitted patient, it is a very high risk patient, then please do use that. So friends, I sum up that if you have a low risk patient, all have received rectal suppository, standard cannulation, nothing else to be done. If it is a difficult cannulation, then PD stenting should be done. If it fails, then aggressive hydration. If you have a high-risk patient to begin with and standard cannulation risk, then you may give a aggressive hydration or not. That's a different thing. In difficult cannulation, PD stenting, if PD stenting fails, then aggressive hydration. And I sum up that there is no unnecessary ERCP. Assess patient's risk of post-ERCP pancreatitis. In difficult cannulation, introduce pre-cut, alternate techniques, and get the expert to do it. Indomethacin diclofenac suppository can be used in all, should be used in all patients. We use it in every patient. Stent PD in high-risk patients. Aggressive hydration in peri-procedural period, but need further studies. Thank you very much.
Thank you, sir. Now I would like to invite Dr. Chalapati Rao for his speech on autoimmune pancreatitis, diagnostic pearls and pitfalls.
Good afternoon, everybody. At the outset, I would like to thank the team Gangaram Hospital, Dr. Anil Arora sir and his team. So the topic assigned to me is to discuss on the diagnostic pearls and pitfalls on autoimmune pancreatitis. We know that there are two types of autoimmune pancreatitis. One is type 1, that is most common, seen in beyond 60 years of age, but early age group, especially children, can suffer with type 2. Males predominantly suffer with type 1. Serum IgG4 is predominantly elevated in type 1, but only 10% in type 2. Other organ involvement, kidneys, salivary glands, etc., can be involved in type 1, whereas IBD is commoner in type 2. Type 2 predominantly presents with acute pancreatitis. Painless jaundice is predominant presentation in type 1. Histologically, type 1 is lobular centric and type 2 is duct centric. Lymphoplasmacytic infiltration is seen in both. Fibrosis and obliterative phlebitis are very characteristic of type 1. Whereas these two specific features, the granulocytic epithelial lesion and granulocytic acinar injury, they are very common in type 2. IgG4 in the histology is predominantly present in type 1. Of course, almost 100% of people, they have steroid responsiveness, but however, relapse is more common in type 1 than type 2. So after the HiSCR criteria, various international experts have come together to publish this ICD-10 criteria for type 1 and type 2, published in Pancreatology almost 15 years back, taking into consideration the parenchymal imaging where there is diffuse or focal enlargement of the pancreas, there can be diffuse or multifocal strictures. The serology is positive, especially in type 1, more than 2 times upper limit of normal is very much indicative of type 1 autoimmune pancreatitis. Other organ involvement is seen in, as I have discussed, histology showed lymphoplasmacytic pancreatitis, storiform fibrosis, obliterative phlebitis, etc. And response to steroids for at least 2 weeks can cause radiological demonstration of resolution or improvement in pancreatic and extrapancreatic manifestations. Coming to type 2, the exclusion is basically the other organ involvement except for IBD and also serology. Rest all are almost similar. Histology I have already discussed about the predominant granulocyte infiltration and the duct wall involvement. But if you see the pearls and pitfalls, we see that overall autoimmune pancreatitis is a bit rare, but is increasingly recognized, and we start suspecting them, especially in pancreatitis and obstructive jaundice. Type 1 is more common in Asian and elderly men, and it's a part of IgG4 related systemic disease. Type 2 is more seen in younger patients associated with IBD and no systemic IgG4 disease. So always consider autoimmune pancreatitis in the differential diagnosis of painless obstructive jaundice with a pancreatic mass, but always be careful that you don't miss a pancreatic cancer and lead them to an unnecessary Whipples. Type 1, obstructive jaundice, weight loss, extrapancreatic involvement. Type 2, recurrent pancreatitis in younger patients with IBD. So a painless jaundice with sausage-shaped pancreas on imaging is a very classic picture, but again, don't miss the cancer because painful jaundice is one feature along with cachexia and constitutional symptoms. Imaging, CT and MR are predominantly and more frequently done. We see a sausage-shaped enlarged pancreas with delayed enhancement and capsule-like rim. In the duct, there can be long and multifocal strictures without marked upstream dilatation. EUS can show diffuse hypoechoic enlargement of the gland and narrowed duct, and it allows biopsy. That is the biggest advantage. So capsule-like rim enhancement with homogeneous enhancement is the highly suggestive of AIP. But the problem is with focal mass-forming autoimmune pancreatitis, which can look identical to adenocarcinoma, warranting histological sampling in these patients also. So if you see various endoscopic modalities in autoimmune pancreatitis, there can be ERP or ERC or intraductal ultrasound. There are various features described, but it has low sensitivity and isolated strictures can miss the diagnosis, and we need some kind of expertise. Regarding EUS or elastography or contrast enhanced EUS, various findings were actually described in the literature.
EUS elastography, the hard and blue area can actually show when there is a mass and even in the surrounding pancreas, but it is a subjective assessment. Contrast enhanced EUS can show hypervascularization in the pseudotumor, but it needs a special equipment and expertise. Coming to serological markers, 80% they have elevation in type 1 AIP, that is serum IgG4, but it is non-specific. We know that it can be elevated even in pancreatic cancers as well as chronic pancreatitis. There are other markers which are actually proposed, but they have very low sensitivity and specificity. But it is about the rise or above the normal limit. If it is rising beyond 2 times upper limit of normal, it strongly suggests type 1 autoimmune pancreatitis. But do not rely only on single marker, because we may mislabel AIP as cancer or cancer is AIP, but 30% can have still normal levels and may not entirely resolve with therapy. Coming to histology, which is actually the biggest thing, a lot of variations have been described. Type 1, as we have discussed about it, histology is the gold standard, but core biopsy is very difficult to obtain. Whatever the features that are described in type 1 or type 2 are from the surgical specimens, and FNA cytology alone is inadequate and it can lead to a lot of false negatives. So endoscopic samplings could be taken from various parts, either from the pancreatic lesion or biliary stricture, core biopsy from the pancreatic lesion, breast cytology or ERCP guided intraductal sampling, or even simple ampullary biopsies. Mind it, if you subject this ampullary biopsies to IgG4, 60% of patients can have positive IgG4 even from ampullary biopsies. But the pitfalls with the EUS tissue sampling is this last point, that is the involvement can be focal and patchy. So that makes EUS histological feature, EUS biopsy and histological features far more subtle. Storiform fibrosis and obliterative phlebitis may be uncommonly noted, but only presence of cellular and inflamed stromal tissue may be the only clue. Often when you are sampling type 2 AIP, the tissue can be more fragmented and the ducts are represented just as detached epithelial cells, confusing them for a GI contamination. And only granulocytic infiltration in the SNR cells may be the only clue. The histological features, actually, if you see a pancreatic ductal adenocarcinoma and start sampling them, the peritumoral tissue can exactly show the features of autoimmune pancreatitis in almost 1/5 of the cases. So please be careful. Again, the mass actually that is seen on CT scan or MRI in the focally enhancing acute autoimmune pancreatitis, actually when you gross or do a histology, there is no mass actually. Okay, so this is a big pitfall, and the storiform fibrosis may not be obvious on the needle biopsy, but which is actually universally seen in surgical specimens. So there is a difference in inter-observer agreement also. You actually may not need IHC for IgG4 in all patients, especially when all the other histological features are there. And beware that there is one marker which is actually identified in type 2, that is PDL1 stain, which is actually very sensitive in type 2 autoimmune pancreatitis. But we also use the same marker for personalized medicine identification of this marker in pancreatic ductal adenocarcinoma. So how do you diagnose them? So not just one marker, you actually go through a comprehensive assessment by either of these two criteria, the HISER-T criteria or ICDC, and a structured criteria prevent over-reliance on a single test. But the pitfall is there is one single thing, that is response to steroids at the end of this criteria as a proof, but it is dangerous if cancer is not excluded. So generally a steroid trial of 0.6 to 1 mg per kg for 2 weeks is done. It gives a good rapid clinical biochemical radiological improvement, but the pitfall is the steroids can shrink the pancreatic cancer temporarily, because the peritumoral edema can also come down, only a trial if malignancy is excluded by biopsy or imaging. Extra pancreatic involvement very common in type 1, so multi-organ involvement gives a tip towards diagnosis of AIP versus cancer, but always do a global assessment whenever you are actually seeing a radiological image, and not to miss out these things by just focusing on the pancreas. There are a lot of differential diagnosis. Always cholangiogram helps if there are long segmental strictures that can identify IgG4 versus a beaded and irregular strictures that are seen in PSC, but always we know the pseudotumor pattern of hilar cholangiocarcinoma, which can be mimicked in sclerosing cholangitis. Treatment and response, typically 0.6 mg per kilo of tapered doses over 2 to 3 months. A long taper is advocated. It gives an excellent response to steroids and it separates from AIP from other mimics. And inadequate taper actually leads to a lot of relapses, and long-term immunosuppression carries some risks. So 40% can have relapse rate, and you need to monitor imaging liver test IgG4. Relapse is often in the biliary tree rather than in the pancreas, and failure to maintain the follow-up can lead to late biliary cirrhosis or unnecessary surgeries. So maybe artificial intelligence can actually is the way to go to diagnose between autoimmune pancreatitis and other forms of diseases, and it has shown that compared to the human eye doing EUS versus assisted with artificial intelligence, the sensitivity and specificity and negative predictive value is higher. So to summarize, autoimmune pancreatitis, a swollen actor, takes the stage, sausage shaped, wrapped in a hazy cage. Is it cancer, fierce and grim, or a mimic, quite hidden within? The script is tricky, lines blurred by doubt, IgG4 whispers, but not loud enough to shout. Imaging paints a cloudy disguise, histology peels away the lies. A steroid spell may lift the vial, but only if caution steers the trail. For every pearl that guides our sight, a pitfall lurks to dim the light. But pearls of wisdom light the way, avoiding pitfalls that lead astray. With patience, skill, and a cautious mind, the true face of AIP may unwind. Thank you so much for your patient listening. Assisted. Thank you, sir.
Thank you for excellent talk.
Thank you.
For the surgeons, there is always a worry of missing out a malignant lesion,
Yeah.
especially when it's localized in the head area. Are there any red flag signs in imaging that can differentiate reasonably between AIP and carcinoma?
I think first thing is upstream pancreatic duct dilatation. That is a very strong factor towards malignancy. Because even in autoimmune pancreatitis, which is forming a focal mass-like lesion, the upstream pancreatic duct will be still thin or stricturous. So that is one thing. And the other thing is duct penetrating sign. So when pancreatic duct is penetrating through a focal mass, so that indicates that it could be an autoimmune pancreatitis. So this is based on imaging only, whether it is an MR or a CT or an EUS, whatever it is. Apart from, the regular things, other histology, IgG4 and all those things.
In these cases, do you routinely recommend serum IgG4 estimation in
Yes.
the patients?
Yes.
But in nearly most of them, in nearly 50% only, they are positive.
True, true. So it is a global assessment, sir. You take all other things also into consideration, the duct, the parenchyma, the IgG4, the histology, everything.
Thank you.
Thank you.
We can take further questions at the end of the session. So our next speaker is Dr. Sameer Mohindra, and his topic is diagnosis of Pancreas Divisum, ERCP, MRCP or EUS.
Good morning. I want to thank Dr. Aniroda, Dr. Ashish and the whole Ganga team for inviting me. When I was allotted this topic looks like a topic for the radiologist. But with the advent of endoscopic ultrasound, we have come into play in evaluation of Pancreas Divisum. Pancreas Divisum, as we all know, is the most prevalent congenital pancreatic anomaly, 4 to 14%, whether you take MRCP or autopsy series. It's basically non-fusion between the dorsal and the ventral buds. What happens is during 4 to 7th week of development, from the duodenal endoderm, dorsal and ventral buds evolve, and then they fuse by 7 week with the ventral rotation, with the clockwise rotation of the ventral bud around the duodenum, and then the ducts subsequently fuse. So what happens is that dorsal duct, which predominantly drains the body and tail of the pancreas by the minor papilla, generally in this condition becomes the dominant duct. So the minor papilla size is smaller, but the duct becomes the most prominent draining, and this relative obstruction is responsible for symptoms of Pancreas Divisum. Now there are different types of Pancreas Divisum. We need to understand that there can be subtle anatomical variation which we need to understand in Pancreas Divisum. Classic, which is the commonest, where you have complete separation. Type 2 is incomplete, where there is a rudimentary communication between the dorsal and the ventral duct. And the reverse PD, where the dorsal duct, which is the dominant duct, opens into the major papilla, and the ventral duct, which becomes the non-dominant duct, opens into the minor papilla. There is another entity which is very important, which is a pseudo-Pancreas Divisum. What happens is, when there is obstruction beyond the origin of the accessory duct, whether it's because of mucus plug, for example, in IPMN, small tumor, or maybe a subtle stricture, it gives an impression of Pancreas Divisum. But here, the normal embryological development is there, But because of obstruction in the major duct, there is compensatory diversion of pancreatic juice towards the minor papilla. So this looks like pancreas divisum, but this is not actually pancreas divisum. This is very important. Now, why we are bothered about making a diagnosis of pancreas divisum correctly? Majority of the patients, they are asymptomatic, but 5 to 10% patients, they are symptomatic. They can present with recurrent acute pancreatitis, they can present with chronic pancreatitis and its sequelae. And mainly in the pediatric data, we find that 25 to 50% of patients can have pancreas divisum in intermittent recurrent acute pancreatitis. This is very important. So there is a significant clinical burden of pancreas divisum in the population, though only 10% are symptomatic. Now, ERCP has been the gold standard for diagnosis of pancreas divisum so far, and diagnostic accuracy is very high. But the problem, it's an invasive procedure. There are complications associated with the procedure. For example, risk of PEP is around 6 to 10%. It can go as high as 15 to 20%. Then there is radiation exposure, especially in smaller children. Then anesthesia-related risk, which are always there whenever we do an ERCP. And now we have got very good cross-sectional imaging, which compensates to a large extent not doing ERCP. So the various modalities available are MRCP, secretin-enhanced MRCP, which is SMRCP, and endoscopic ultrasound. Now, MRCP is a non-invasive method. It gives a very good cross-sectional evaluation of the ductal anatomy as well as parenchyma. For example, if you see the film on the left-hand side, what we can see where the pathology is, whether it's in the dorsal anlag, which is hyperechoic, or the ventral anlag, how is the ductal contour, which part of the duct is more involved, and so on. So it gives a very good cross-sectional imaging. Another advantage which I find is that, for example, a person comes with acute pancreatitis for the first time, and you find that only a patchy involvement of dorsal pancreas is there, and rest of the pancreas is normal. This you can easily pick up on cross-sectional imaging, and you know if the pathology is localized only in the dorsal duct territory, you may be dealing with pancreas divisum. So that's a very good advantage of doing a good cross-sectional imaging. If you look at the sensitivity of MRCP, it is not perfect, 50 to 70%. Various series when ERCP was the gold standard. Now, this is a very interesting slide. This basically demonstrates that you need to have a very good planning of the MRCP, and you need to have an expert radiologist. In this study, what they showed was that when MRCP was first read by a radiologist, sensitivity of MRCP was 60%. But when the films were reviewed by an expert radiologist, the sensitivity increased to 83%. So it basically, interpretation of film is very important. Though there are problems with MRCP that small caliber ducts, very subtle changes in the ductal anatomy may not be picked up the standard MRCP. There are limitations of MRCP, no doubt. Then came the concept of secretin-enhanced MRCP, where we give secretin 0.16 microgram per kg, and then it starts dilating at 1 minute, peak is at 5 minutes, and we do the study up to 15 minutes. Any increase in more than 1 minute of a dilated duct with duodenal filling suggests that we may be dealing with pancreas divisum. It's basically what happens: ductal cells secrete more bicarbonate and water, ducts get dilated, and you get better delineation, better magnetic resonance signals, and more chances of making a diagnosis of secretin. But the problem is, if a patient has got advanced chronic pancreatitis, especially with pancreatic enzyme insufficiency, the duct may not dilate, may not have significant change in the ductal anatomy to pick up pancreas divisum. This is a limitation of secretin-enhanced MRCP also. If you look at the diagnostic yield, sensitivity is 83 to 86%, which is much better than conventional MRCP. Now, we got involved. Why this topic is important is, now the endoscopic ultrasound is coming as a competing modality to diagnose pancreas divisum. There are various signs, there are multiple signs, but 3 or 4 most important signs are absence of stack sign. Generally, common bile duct, pancreatic duct, and portal vein come in one line, parallel, running almost parallel to each other. There is a stack sign. If it is present, then we rule out pancreas divisum. Cross duct sign, PD never crosses the CBD, but in pancreas divisum, when the minor duct becomes very prominent, it tends to cross the CBD, and you can get this sign. Then absent dipping sign, when you see from the gastric body, you see that around the genu, the main pancreatic duct drips down towards the ampulla. This sign is absent in pancreas divisum. Another important sign is when you find that the accessory duct is more dilated as compared to the duct of Werson. That suggests that this duct is abnormal, and there is a compensation dilatation of this duct. And if you find focal changes of whether it's acute pancreatitis or changes of chronic pancreatitis in the dorsal anlag, it suggests that this can be pancreas divisum. So there are multiple signs. People have used multiple different signs to look at it, and the sensitivity has been between 70 to 80%. So advantage of EUS is we can see the whole course of PD. We can see early changes of chronic pancreatitis because of recurrent acute pancreatitis, and we can look at other anomalies which can be associated with Pancreas Divisum. Now, this is a very recent study. It's not a study, it's a retrospective analysis of 120 PD patients from 3 centers in China, which looked at Pancreas Divisum. And what they looked at is, what they did was they did linear US, then they did ERCP, and then they looked at the MRCP film. If you see the difference in sensitivity between linear US versus MRCP, linear US outscored conventional MRCP. But the problem is, patients who had severe pancreatitis, who had chronic pancreatitis or extensive stone burden, EUS doesn't tell you the whole story. So these are a subset of patients where EUS may not be a good modality to look for Pancreas Divisum. If you look at head-to-head trial, MRCP is much, much inferior as compared to radial or linear EUS. This is a recent meta-analysis which looked at EUS versus secretin MRCP, and what they felt was if you are looking at the etiology of pancreatitis, EUS is better. It picks up sludge, it picks up microliths, it picks up CVD stone, it picks up early change of chronic pancreatitis. But if we want to look at a ductal and biliopancreatic ductal anatomy, secretin MRCP is slightly better, but almost equal. But in this review, it says basically slightly better with secretin MRCP. So if you look at EUS, it has got a high sensitivity. You have an option of doing the procedure to diagnose Pancreas Divisum, but it is highly operator dependent, need expertise, and availability is always an issue. If you look at secretin MRCP, sensitivity is high, but availability and cost is a problem. So the take-home points are, PD is a common clinical problem. In unexplained idiopathic recurrent pancreatitis and chronic pancreatitis, secretin MRCP or EUS can be used, whichever expertise is available at your center. I would not say that EUS is better than secretin MRCP. Whichever of the two modalities available, whichever you are comfortable with, that should be used. We need to have standardized protocols for evaluation of patients with Pancreas Divisum. Most of the data has been retrospective. And now none of the modalities are perfect. See, sensitivity is around 90%. So we need to look at maybe modality like contrast enhanced EUS or using artificial intelligence to interpret the images which are not very convincing. And we need to have an algorithm which is diagnostic integrative with therapeutic protocol so as to have minimum cost in evaluation and management of this patient. Thank you.
Thank you, sir. So questions will be at the end of the session. So now I will like to request Dr. Govind Makharia to please come onto the stage for his talk on avalanche of new drugs of constipation. Where does poor clinicians go?
Thank you, chairpersons and moderators. Good afternoon, everyone. Thank you, Dr. Arora, Dr. Ashish, and the team Gangaram for kind invitation. I think it's a wonderful meeting. Very important topics, and very important talks for clinical practice. So again, coming to one important topic, which is constipation and how it is important, what are new drugs in constipation and how they are useful in our clinical practice. So look at the first thing for goal of treatment for constipation. This is fundamental, that the first goal is that the patient should have improvement in the passage of stool. So they have incomplete stool become complete, and also difficulty in passing stool becomes better. The secondary goals are that they pass 3 stools per week. This is a definition from the West, but in our country we know that everybody wants to pass stool every day. So, and a third one, that overall there should be better quality of life. So they are fundamentals of treatment of constipation. And if you look at the drugs which appeared in practice over the last 100 years, so 100 years back it was all few drugs like fibers, phenolphthalein, castor oil, and there were no drug available. But in 1950, the first drug which came was bisacodyl, followed by sodium picosulfate, followed by tegoprubart, which is now not used because of its cardiac side effects. Following that, new drugs over the last 50 years, many of them, including levetiracetam, liraglutide, paliconitide, prucalopride, and also ilobaxetine. But all these drugs have developed over last few years, and let's look at how they are. So once you want to treat patient with constipation, there are 3 principles which are relevant. Number 1, the first principle that there should be patent tract. There shouldn't be stricture, there shouldn't be tumor. The duct is patent. The second is that the amount of stool which is there should be good, and it should be not dry, it should be moist stool. The second point is that they should have a good intestinal motility so that the stool can pass through. And lastly, there should be good anorectal coordination, that's called defecatory apparatus. And all 4 are required for a good defecation. Any problem anywhere will lead to. So look at what are the drugs which can. Patent duct, we are not going to talk today. We know that for second, that to increase bulk in stool, the principle again increase the bulk of stool by giving more fibers, and can use hyperosmolarity like polyethylene glycol. Right? Now coming to the water content in the stool, and water content in the stool is very important. Unless stool is moist, it will not pass through. It will be difficult to pass through the colon, also as a defecation. So we need to put water in the colon, and how do we do that? So if you use that, the concept is there are multiple receptors in colonocytes all through the colon, mainly in the right side of the colon. There are receptors for chloride channels, right, and CFTR channels. So if you activate these chloride channels, the chloride will come to the lumen, sodium will follow, and also water will follow. Therefore, there is more water in the colon. This is called chloride channel activators, and there we have many drugs, including levetiracetam, linaclotide, and also plicanatide. All 3 drugs are now available in our country. So coming to levetiracetam, which is a classical calcium channel activator, and therefore it will move more calcium, more chloride into the lumen, therefore more sodium, more water, and this drug is useful. Also, if you have more water in the colon, they will further increase the motility of the intestine, and therefore better intestinal flow and better improvement in constipation. So this drug have been used in 2 doses in functional constipation, 24 microgram twice a day, and in IBS is a lower dose, is 8 microgram, and this drug is available in the dose of 24 microgram in our country. The second drug, which is called linaclotide, now available in India now, and this drug again, it is little better than placebo. These drugs, none of these drugs are like nirvanas. These drugs have little better effect on the placebo, but they're important. And the third drug, which is called plicanatide, again same principles, increasing more sodium, more chloride, and more water into the colon. And this drug is available in 3 milligram. This is used once a day. Plicanatide is used 3 milligram once a day. Again, little better than placebo. Now coming to third principle, that do something to increase colonic motility, and they're called colomimetic drugs, and there are many of them. The drugs which are available, which are in practice, are bisacodyl, sodium picosulfate, and prucalopride. Other drug, tegosterol, was banned, and a couple of more drugs still are, like valustag and nanopride, are still under clinical trial. They're not available at this point of time. Prucalopride, again, in different doses, 1, 2, and 4 milligram, mostly 2 milligram doses, and it also improves complete bowel movement in about 20 to 50% of patients once you use it. Other class of drug, which is called ilobixibat. This is a IBAT blocker. IBAT is a intestinal bile acid transporter, and these are the receptors in the terminal ileum. So look at a bile transport. Normally we have about 500 milligram of bile per day secreted by the liver, come to biliary tract. They get conjugated, so come to terminal ileum. In terminal ileum, they get deconjugated, and by IBAT, they get absorbed into the portal circulation. 95% of it is get reabsorbed, and rest 5% further get conjugated and secreted into the stool, right? So this, if you increase bile acid by blocking IBAT, will have a more bile in the large intestine, therefore better motility of intestine, and better it can improve constipation. And the drug which is available now is ilobixibat. Many companies are making it. The 2 clinical trial, and there are many phase 1, phase 2, but most experience are there from Japan only. They have not been used elsewhere in a clinical trial. And both studies shows, one is a phase 3, a 2-week study to show how many patients get better in terms of a complete bowel movement, and over long time looking at safety of the patient. And looking at both the studies together, what we find that the spontaneous bowel movement is much better if you use ilobexibat 10 milligram a day, right? And over long term also, it is a improved bowel movement continuously. If you use for 1 year, the bowel movement remains better. And what we call bowel movement better is a complete spontaneous bowel movement. So, and this is used in the dose of 10 milligram ilobexibat, and we have a 5 milligram tablet. So we can start with 2 tablets and then cut down as per the symptom relief. Now, the fourth part is that if somebody has a difficulty in anorectum coordination, it's called pelvic floor dyssynergia, or people also call outlet obstruction or functional defecation disorder. And in this kind of patient, the only treatment is biofeedback, right? And in this patient must not be given fibers. The fiber will further worsen their symptoms. So how do I identify those patients who have manual evacuation, those patients who have to strain a lot, those patients who have a persistent desire to pass stool? These are the patients who have a pelvic floor dyssynergia. So coming to of all the drugs, which drug is how much effective? I think for a clinician, this point is very important. Which drug do I choose in my practice? And this is a data from a systematic review and network meta-analysis done almost 5 years back, and which it shows that efficacy of spontaneous bowel movement per day, or per week, more than 3 per week, there's an error there, more than 3 stools per day for 4 weeks. This is the outcome. And if you look at this outcome, the most effective drug is diphenylmethane. This is called sodium picosulfate. This is the most effective drug, and almost 55% will fail, but 45% will have improvement in symptom. So sodium picosulfate is #1 drug. Then comes linaclotide, little improvement in 25% patients. Then in high doses, but in lower doses, which is about 10%, and prucalopride about 18%. Ilobexibat was not included in this systematic review. So what is number 1 need to treat? Again, this is an important question for clinician, that for ilobexibat is 3, and for others is about 5, 1 per 5. So NNT is 5 for both for linaclotide and also levoprostol, but for ilobexibat is 3. So putting everything in summary, how do I choose a patient? I have a patient with chronic constipation, and my diagnosis is functional constipation. The first line is fibers, or polyethylene glycol, or liquid paraffin. And if they don't respond, one can use bisacodyl or sodium picosulfate. If they don't, then you can add any one of them, like prucalopride or calcium channel activator. I think nothing there to choose one over other. You might consider the cost or side effect, but otherwise, efficacy-wise, nothing here to choose about. And we don't have a drug-to-drug clinical trial, so we don't know which drug will perform better in a given patient. If somebody had a pelvic floor dyssynergia, what not to do is no fibers to these patients, and biofeedback remains the most effective treatment, and it works in about 2/3 of patient biofeedback will work. And also a different exercises like diaphragm exercises and also relaxation exercises. If they don't have biofeedback in a center, then one can use something which makes the stool liquid, like use polyethylene glycol or liquid paraffin. If somebody has slow transit constipation, how do we recognize? No urge to pass stool, and don't pass stool for days together or weeks together. There's a slow transit constipation, and that you need to improve colonic motility. And how do we do that? We do by doing prokinetics like bisacodyl or sodium picosulfate or prucalopride, and sometimes pyridostigmine in those patients who have megacolon, and some will require surgery if they have a long-standing megacolon. So, yet the constipation affects about 10% of our population. Defined constipation, perceived 50% of the population, but we don't have a best drug yet. And we need to really have many more drugs to come. And I think in today's time, you saw the chart of drug development, which was taking decades for new drug to come. Now with AI, we are likely to have more drug more quickly. And this is shown in antibiotics. like getting new antibiotics is so important for mankind, and getting antibiotics is so difficult. So now a lot of AI tools are being used to find out a particular target, and against which to design a drug using AI. And same can be used in those patients who have constipation. Not only that, but also AI can help into a good clinical trial. I think with that one-line summary, that current treatment is not very effective, but still we have many drugs. One can choose depending upon the patient who can afford these treatments, and that's one major factor. Otherwise, first-line treatments are the best probably. With that, thank you so very much.
Thank you, sir. The house is open for question and answers.
Yeah, excellent talk as always. I think your last slide was very good, that the treatment is insufficient. Even if the patient passes stool, they are still not happy. They want to be as good as a person who doesn't have constipation. So where does the problem lie? Does it lie in the gut or in the neurons or in the brain in patient with constipation, say functional constipation?
So I think it's not in the brain, I think it's in culture, because it is seen that Asians, the anxiety and depression are centered towards abdomen, right? So most Asian, they have, if they anxiety or depression or any such issues, psychological issues, everything they point to the abdomen. And that's why most Indians, and this has been taught from our childhood in every family, that you must pass stool every day. And you don't pass stool every day, there's something unwell with you. And then you go to doctor, and the same thing goes on in the families. And therefore, there's a lot of data that those patients have a father has a functional bowel disorders, the son or daughter also has a functional bowel disorders. So it cultural probably. And I said that if you ask Indians, 50% Indians will say that I'm constipated, right? But and they have different definitions of constipation. But if you look at typical definition of constipation by Rome criteria, only 10% are. So these 40% are perceived constipation. They perceive they have constipated, but they're not truly, there's no disease inside, right? And in those situations, probably reassurance is probably the best technique, because you can add fibers, you can add any of these drugs, the fulfillment of passing should not be there. Therefore, perceived constipation, I think, is a major thing. Talking to the patient, I think that's the best thing to do. I don't think it will work, because there's somewhere else. You can use fibers, still they will come back to you, because as long as you give fibers or any drug, the symptom will get better, but they get back to square one. So therefore, I know this is a very important discussion, that Indian toilets versus Western toilets, and I personally don't believe in it, but I don't know the great physiology of this. Uday Ghosal, dear colleague, he believes in Indian squatting position is better for passive stool, which is the movie also, right? But I'm not sure there's great evidence to show that.
Sir, question from me. Excellent presentation. So when a patient comes to you and says that he uses Ayurvedic medicines, Pet, Safa, Kayam, Churun, what do you, and he feels satisfied, what do? Do you suggest him to continue those, or you withdraw and then suggest? What is your approach to those patients? And there are a significant number of them.
I think this is a question which is really a dilemma for all of us. How do you, somebody is doing well with Ayurvedic medicine, how do you stop it? And you know your drug is not going to work. You know efficacy of drugs. So I tend to tell them, but in the back of my mind, I say, chalta chalne do. Unless they are, but certainly, because I want to first, if I take Ayurvedic medicine for a long time, I want to see that there is no disease inside. I want to make sure that with a good history and maybe some investigation find there's no underlying disease. But I tend to continue.
Okay, thank you.
So my question is, what is the safety profile of IBET group, and when we're talking in terms of bile acid pool and the B12 deficiency?
Which one?
IBET group of medications.
I think the data would suggest this is not a major side effect. Minor are always there, and minor are certainly the most important, being the pain abdomen, because of little more water, little more cramps. So bile acid will lead to little cramps, and that's one major effect.
Could you see the bile acid pool and B12 relation with that? Because ultimately, if we look on physiology, does it really interfere with that?
Your point, but I don't have answer to that, sir.
Yeah, there is a good data to show that it does not alter the bile pool, because of the total bile pool, only 10% is affected by the IBAT. There is no recommendation of adding supplement with B12. Very clear answer.
Dr. Ajay has gone, but I just want to mention, recently in last 2-3 months, there is a study published in GI endoscopy, randomized controlled trial comparing rectal diclofenac with cooling of papilla with cold water after post-ERCP to prevent post-ERCP pancreatitis. In this, what they have done, they have taken around 100 ml of water, put 5 to 7 cubes of ice, and after procedure, they instilled endoscopically 5 ml of water. Papilla was cooled and for 2 minutes, and then the suction was done. And this procedure, they repeated 5 to 7 times, and what they found was development of post-ERCP pancreatitis was significantly lower in cooling papilla with cold water, and it was half of the patients, it was half as compared to that of development with rectal diclofenac.
Yeah, this is a Japanese study.
And second recently study published, EUS versus MRCP in diagnosis of Pancreas Divisum. EUS is better. This is last 2-3 months. But however, I felt this is a prospective study, not a retrospective study.
No, the MAO study which I mentioned.
You mentioned retrospective study.
1398 patients, out of which 120 were PD.
Yeah, you mentioned retrospective. I think it's a prospective study.
No, I couldn't get a prospective recent study. So this is the largest data on Pancreas Divisum.
This is last 2-3 months.
This is GI endoscopy, 2025. Yeah, it's the same study, MAO, from China.
Sir, we know that long-standing slow transient constipation leads to dilatation of colon. How are there any clinical pointers to differentiate it from ultra-short segment Hirschsprung?
I don't think they are a clinical trial, and I think ultra-short Hirschsprungs. I think I don't know much, but my personal feeling is that ultra-short segment and multifocal neuronal deficiency are same disorder. It's just about one part of segment is the loss of ganglions, but other part also have. And therefore, we always ask for that Hirschsprungs is fine. Hirschsprung can occur at any age. So those who have a anorectal loss of neurons or ganglion, we call Hirschsprungs. Others are still there. So how do I say there's only Hirschsprungs and there's no proximal extent of that loss of ganglion? Very difficult to differentiate, right? But I think there's a lot of overlap between these two. And we always ask, you think of a slow transient constipation, two things always ask that does you have pan-GI? How do you know pan-GI? Most of us don't have colonic manometry. So we do upper GI manometry. I do esophageal manometry. And this also shows there is a lack of peristalsis, right? Or ecclesiocardia phenotype, right? In that you say this is a pan disease, right? If they also have gastric symptom like dyspepsia, they can also have gastric dysmotility. Right? And advanced stage certainly obstruction. But they are mostly multifocal disorders. And one more thing, that if you have a slow transient constipation, I don't have anything else to do. No drug available. Right? What I suggest every time that make the colon clean. How do you do that? Give a lot of PEGLEC, polyethylene glycol, so that slowly over time they clean. Because the stool, when they get accumulated in the colon, they become tumor-like. And this tool will not allow the stool to pass further, and further the whole process goes on and become megacolon. So therefore, when you suspect a slow transient constipation, always use a sweeping force, something to sweep the colon by giving a lot of hyperosmolar agent like polyethylene glycol. Despite it doesn't work, but that's the only thing you have, nothing else, unless you have to operate later. So all patients with slow transient constipation must give a lot of hyperosmolar agent, just they don't accumulate further.
Sir, one question to you also. After this sharp trial, is there any point in looking for PD at all?
See, the issue is, there are certain issues when you want to have a cause and effect. Number one, is that entity more common than general population? If you look at it, it's around 8 to 10%. So there's no difference. The problem is that their incidence in idiopathic recurrent pancreatitis and chronic pancreatitis subset, it's higher than general population, number one. Number two, there are studies, most of them are retrospective, then in patients who are symptomatic, they get relief of their symptoms with either sphincterotomy only, with or without stenting. So The jury is still out. In pediatric age group, yesterday I had given a talk in CMC Vellore. Basically, in pediatric age group, they are very clear that it works in a subset of patients who are symptomatic with idiopathic recurrent and chronic. In adults, there are no clear-cut guidelines, but we will be guided by the symptoms of the patient and the morphology of the duct. If the duct is dilated, patient has got symptoms, there are no changes of advanced chronic pancreatitis, and we are not thinking of neuropathy or neuropathic changes being responsible for pain, I think we should go ahead with a trial of treatment.
Yeah, partly you answered the question. My question is, in the absence of morphological changes in the duct, in an adult with incidental pickup of pancreatitis, which otherwise you presume to be because of the recurrent acute, so when do you intervene? Because every time you intervene, your incidence of pancreatitis will almost 4 to 5 times than when you do a conventional ERCP.
See, it depends upon what kind of symptoms the patient has, number one.
Recurrent acute pancreatitis.
Recurrence of symptoms, frequency of symptoms, severity of symptoms, or do we have an alternative pathology to explain those episodes of pancreatitis?
If there are none, and in no morphological changes, that is the dilemma.
Morphological change means non-dilated duct.
Not dilated
so
duct, no calcification.
what we do is, if patient has got significant symptoms with a huge healthcare burden, then what I do is I do only a minor papillary sphincterotomy and leave. This is a therapeutic kind of a trial, not scientifically justified. But then if the patient is being affected by the pain, then I think doing a simple minor papillary sphincterotomy.
What is the risk of doing developing pancreatitis?
8 to 10%.
8 to, that is significant.
I agree. You need to, especially in pediatric age group, we do a lot. Adult, we do. One?
Just have one question for Professor Macharia.
Yes, that's always there. But in
biofeedback, I've been listening a lot about this, but don't know how to do it. Biofeedback training for constipation.
So biofeedback is done through equipment where you put a balloon inside. Okay. I think biofeedback is a technique where you require special equipment where you train the coordination of anorectum, right, and puborectalis relaxation, right. Where what you do, put a balloon inside, right, and ask the person to defecate the balloon, right, and see that how does the patient responding to, and there's a picture in front that if you ask the patient to contract, like pass, once you do after manometry, ask the person to pass stool. So ask him to do defecation. So what is defecation? The pressure will go down, and see on the screen the pressure is going down. Ask them to increase tone, again say pressure is going up. This is how you train their mind that how to coordinate anorectum. It's called biofeedback. And this is very, very important technique, especially those patients who have a pelvic floor dyssynergia. Right? It's effective in almost 2/3 of patients. If you use 6 sessions of biofeedback, we give over 6 weeks time, weekly so kind of.
Professor Macharia, I really enjoyed your talk as always, and just wanted to ask, there's no evidence to support IBAT in drugs in cholestasis, but people do use it, and I would like to know your comments.
Dr. Arora is there?
Dr. Arora has left.
Okay. Dr. Arora, you want to take the question? You spoke
Usage
last time
of
on this.
IBAT drugs, Alobixibat in cholestasis, and there's some people do use it. So.
Patients who have long-standing cholestatic disease, especially in primary biliary cirrhosis, primary sclerosing cholangitis. But then there are other better alternatives than Eloxibat, which is good. There are newer modifications which are more useful. This drug is primarily meant for constipation. Newer derivatives are meant for liver diseases.
With the newer drugs available for constipation like secretagogues, we usually secrete water inside the colon. But most of the studies have shown that it also reduces the pain irrespective of spontaneous bowel movement. Despite these drugs don't act on muscle, what could be the reason for improvement of pain?
I think just a better evacuation.
But despite no improved spontaneous bowel movement, there was improvement in pain in most of the studies.
Yeah, that's a question.
Yeah. Any attempt at measuring objectively the colonic motility or small bowel motility? Where are we?
I don't see much literature. Unfortunately,
the GI physiology, the scientists and clinicians doing GI physiology are very, very few, very, very few. In fact, in 60s, 70s, 80s, well, luminal gastroenterology was on top. But ever since hepatology and endoscopy came, there are less people to really work on GI physiology. So very few studies on colonic manometry. Doing is not a problem, but they're not well standardized yet.
Thank you, sir. So we conclude this session. And I will invite Dr. Ashish Kumar, our organizing secretary, to give the concluding remarks.
So we have come to the end of the 28th CHBD conference, Clinics in Hepato-Biliary Disease, and over last 2.5 days, what we witnessed is immense enthusiasm in all of you in participation, in all the lectures which were given by the speakers, and all the moderators and chairpersons who were chairing the sessions and moderating the discussions, and most of all the audience which actively participated. And over the years we have seen the same enthusiasm, and which has been growing over the years, and we really are thankful for all of you for this. And I would like to extend my thanks to each one of you for coming here every year, and I extend my invitation for you to come next year also to the next year's CHBD conference in 2026. The dates we will soon announce, but most likely they'll be in September 2026. And now I would like to invite Dr. Praveen Sharma, who would give a formal vote of thanks to all of you.
So thank you everybody. On behalf of the organizing committee, Dr. Anil, Dr. Ashish and myself, I wish to extend my gratitude to all the speakers, chairperson, moderators for taking out their time and give an excellent, crispy presentation for all of us. We enjoyed a lot. The only thing which I wish to say that we are open to hear any suggestions, any good things from your side, so that we can improve our academic program on the later conferences. Because no, we are 2.5 day program, jack-packed. It's difficult to hear right from the morning to the evening. If any good suggestions, we are okay for that. So with that, I like to thank all the company peoples, the Pranav and other team for supporting this conference. Thank you all.